Next up, some acknowledgements. This webinar will be about an hour or hour-ish long with a Q&A at the end. Dr. Jacobs definitely will go through more in a bit, but we're here to bust myths about fat phobia and gender affirming surgical care, breaking down the science, also just addressing common health concerns that patients have with higher BMI. I also just want to have a caveat and say that like these medical systems are historically very like fat phobic and excluding folks from necessary, like medically necessary gender affirming care that can feel really difficult and really activating. And that like these intersections of transness and fatness are often met with a lot of scrutiny and a lot of violence in varying levels. And so, while we will try our best to educate and inform, to empower and help you make better like informed decisions, these topics can be really sensitive and may feel activating as well. So if you are experiencing any difficult thoughts or need support, I always recommend Trans Lifeline. They are amazing. And also the Trevor Project as well. They have some warm lines that can support you. Moving forward, tech accessibility, we have automated live captions. For the questions, there is a Q&A box that you can submit them into. When you're chatting, make sure it says everyone instead of hosts and panelists when you're sending messages over. Last but not least, this webinar is recorded. There will be some resources sent afterwards, as well as a post-event survey. So with that, I will pass it over to Dr. Jacobs, and we can get this presentation started. Thank you.
Okay, I'm going to try the tech part of this now. First, you're going to see a nice picture of the forest, and hopefully in a minute, the presentation. Okay, you seeing it?
Looks perfect.
Okay, well, once again, I'm really excited about doing this. As I said before, these really are two subjects that I care very deeply about. And it's interesting because I think that this whole topic is not only an issue in healthcare and in surgery and gender affirmation, it is probably one of the hottest topics in the world. And some of the evidence of that is the manufacturer of Ozempic, which is a Denmark company called Novo Nordisk, now has a net worth of greater than the GDP of Denmark. And so that's the economic impact of this. I think that it's worth pointing out that even though many people in the United States don't have insurance for Ozempic, which means they're paying over $1,000 a month, the demand has nevertheless completely outstripped supply. And the blockbuster status of Ozempic and its cousin Zepbound has caught everyone by surprise. What surprises me is that a drug that effectively treats weight would surprise anybody that would become a blockbuster. But that is, in fact, where we're at right now. And I think some of that has to do with the approach that we have in healthcare to quality of life issues as opposed to length of life issues. There's actually a drug, Belvic, that was on the market until just the year before Ozempic was approved. And that was the best drug at the time for weight loss. And it was taken off the market because of a very questionable impact that it might have on cancer rates. But basically, it told millions of people that you can no longer get help for your weight management because there's a question about the length of life issues. And I'm going to circle back to this later, but I do think that there is a fundamental tension in modern healthcare between quality of life and length of life. And that certainly plays out in gender affirmation as well. And of course, the ultimate modern day test of our worldwide attention span is the number of views on TikTok. And you can see that Ozempic has just skyrocketed in the last couple of years. Okay, so we're going to talk a little bit about some of the new concepts in BMI management or weight management. We'll talk about BMI in terms of surgical risk, in terms of surgical technique planning, and a little bit in terms of aesthetic outcomes and additional aspects of body contouring and liposuction. And I'm going to be focusing pretty exclusively on top surgery, mostly because that's what I do, unless I'm assisting some of the other surgeons in our group. And I think it's obviously the most common procedure, but it's also where this tends to play out the most in terms of the direct impact between BMI and surgical implications. Okay, so the world until June 4th, 2021, when Ozempic was approved by the FDA for weight management. And it was the first in this class called GLP-1 agonists. And until that day, since we didn't have a medical solution, what did we do? We blamed the patients. And we said, this is so simple. It's calories in, calories out. You can increase your calories out with exercise. It's just a question of self-control and restraint. What's so hard about that? Basically saying that if you weren't able to control your weight, it was because you didn't have adequate self-control and restraint. And then going one step further, that was what I just said a minute ago was for adults. What about children? So this is a screenshot of the Registry for Clinical Trials Worldwide. And you can see I just typed in childhood obesity. And what you get in the opening screen is non-pharmacologic alternatives for childhood obesity, the Baby Act trial, which is a lifestyle intervention trial, another study looking at habituation to food as a risk factor for pediatric obesity. What's the bottom line in here? If your children are overweight, it's because you're probably not parenting right. And again, we blamed the patients. And I think that, quite frankly, that was a fairly tragic period in American and worldwide healthcare, that was the approach that we took to something because we didn't have a solution. And then came June 4th, 2021, when Ozempic was approved. And all of a sudden, now we have a solution. And so we can look at this in a much more sophisticated way. And we suddenly could talk about the fact that the overwhelming majority, if not all of the interventions in lifestyle and diet modification, barely yielded fruit. I think if we looked at all of the studies and interventions over the course of the last 50 years, we could probably say that 1 to 3% of people who go into these types of modifications will lose weight and keep it off, and that greater than 95% of people will either not lose weight or they'll lose weight only to put it back on later. And for sure, it will be a daily, if not hourly, struggle. We now know that metabolism is much more complex than we used to think it was. We have many internal mechanisms that work to thwart weight management, no matter how hard one tries. We know that as you lose weight, metabolism actually slows down, and so you burn fewer calories than before you lose weight. And of course, appetite goes up. And so everything is fighting you and making it almost impossible to lose weight and to keep it off. I like to say that asking somebody to eat less is a little bit like asking somebody to breathe less. Good luck with that. And now, again, as I kind of alluded before, since June 4th, 2021, we have effective medications and we can completely rethink the way that we talk about weight loss.
To interject, Dr. Jacobs, someone said, would Ozempic be the only option for patients wanting to lose weight? I'm sure you're going to go more into it later, but wanted to get your thoughts.
No, I appreciate that. I actually wasn't going to go much deeper into that aspect. The two drugs that are really leading the way right now are Ozempic, which is also known as Wegovy, and Zepbound, which is the Lilly equivalent of Wegovy. And those are the bulk of medical intervention right now, other than surgery, for weight management.
Thank you.
Sure. Okay. So having said that, though, and I promise not to sugarcoat anything, there are implications of BMI and surgical risk. And so this particular slide is for surgery, kind of all comers. This isn't gender affirmation surgery or top surgery. And so we know that over a BMI of 35, there are risks that go up, such as clotting in the legs. And if the clotting gets loose, that becomes an embolus, and that embolus can go to the lung and be dangerous. We also know that over a BMI of 35, it can be more difficult for the anesthesiologist to put in a breathing tube and to maintain breathing. and that there's more sleep apnea over a BMI of 35. As we get over a BMI of 40, there are certain implications in terms of the cardiac and respiratory functions. The right side of the heart has to pump harder to get blood through the lungs. And so we often, over a BMI of 40, will ask for certain cardiac workups to make sure that the heart is functioning effectively. We do see more wound infections and pneumonia with a BMI of over 40. And then over 50, you really need specialized care in order to be able to deal with the airway management, as well as all of the other risks that are present in lower BMIs. Having said that, there's some good news. And I think this goes to what you were saying, Rai, about the approach of healthcare to high BMI patients. So yes, we have some higher risks of complications and even readmission with a BMI of greater than 50. We know that we have a longer incision, which may lead to more wound infections and certain wound complications. But as this study from just last year shows, we actually don't have a higher rate of severe complications. And so you can sort of back up for a second to that question of quality of life versus length of life, and how many people are denied this procedure because of some possible or hypothetical length of life risk, completely ignoring the impact that it might have on quality of life. And so the way I read this is it's now, especially after this study, particularly difficult to say we're not going to offer somebody this profound quality of life intervention because of some risk factor that would make it inappropriate. Now, I will say there are some BMIs that are so high that in the operating room, it just actually becomes logistically difficult with the OR tables and some of the different tools that we have, but those are really high BMIs. So I hope that puts a little bit of the risk aspect into an appropriate context. Okay. What about BMI on the choice of surgical techniques? And I can kind of divide these techniques into categories, if you will. And so this slide is for the short scar technique. And when we talk about short scar, we're basically talking about keyhole and periareolar. This is the keyhole where it's just an incision around the circumference of the areola. And you go through there to remove the underlying breast tissue, and then you just close the incision. So you haven't removed any skin, and therefore the skin really has to retract on its own. It has to be elastic enough that it redrapes over the chest wall and doesn't leave some unsightly looseness that might occur if you did this on someone who was too big. And then the periareolar approach is a sort of, some people call this a donut approach because this part here looks like a donut, but you make a circle around what will be the future circumference of the areola. So it allows you to make the areola smaller. And then you make a larger circle so that everything in between those two circles gets folded underneath. And you can remove a little bit of the extra skin that way through the periareolar technique. But you can see, as this drawing suggests, it's still a relatively thin person with a relatively small breast. Otherwise, either this outer circle would have to be way too big, or you would end up with laxity on the chest wall. Again, that wouldn't be particularly aesthetically pleasing. And one little trick I can share with you is that we often would look at this angle right here, the angle from the chest to the bottom of the breast. If that angle is greater than 90 degrees, then most likely this would be someone who would be a candidate for the short scar technique. And here's some examples. So here, again, the keyhole where you just remove the underlying tissue through that little tiny incision. So here's somebody, you can see that angle right there is much greater than 90 degrees, fairly thin, fairly small chest. And so their skin retracts pretty nicely after you do the keyhole technique, and you can see that from the side. Here's a periareolar technique, and you can see this is just about at 90 degrees, so probably a little bit too much for a keyhole, but appropriate for the periareolar technique. You can see the circumference goes all the way around. The areola we're able to resize it so it's smaller than it was when we started. And again, in someone relatively thin with relatively small chests, we can do the short scar technique. So the next category is the buttonhole technique, which is a procedure kind of all to its own, because this is a procedure that we often will go to when someone is asking to retain sensitivity. And the reason why it does retain or can retain sensitivity is because we're actually leaving the nipple areolar complex attached to this tongue of tissue, or what we call a pedicle. So here's the chest wall, and this is the pedicle of tissue, and the blood can go out to the nipple and back to the chest wall. And hopefully we're also capturing some nerves in here that will offer this sensation at the end of the procedure. But you can see this too, as this image depicts, is best on someone with a relatively small chest and relatively small amount of breast tissue, because otherwise this pedicle gets quite long, which means that the blood has to go a long way out and a long way back, and that puts it at risk of inadequate blood flow. And also, as it gets that long, it gets quite bulky. And so you definitely would sacrifice the contouring that you might want for if you want a relatively flat chest for the hope of maintaining sensitivity. And so this operation too tends to be best for people who are relatively small. As you can see in someone, again, much larger, this is how far the blood would have to go out and all the way back on that relatively thin pedicle of tissue, and that would be just a pretty significant risk. And I would even say that every time I have been somewhat disappointed that I've done a buttonhole procedure, it's exactly for that reason, that the pedicle gets a little bit long and you see the tissue is struggling just a little bit, and you don't sleep until that person comes back and you see that everything is okay. And here's an example of somebody that did have that technique. And you can see, again, relatively thin, relatively small chest, and then you can get a nice result with the buttonhole technique. So where that takes us then is to the double incision, which is really the go-to procedure for anybody other than patients that are particularly thin with relatively small breasts. And this is by far the most common procedure done in top surgery. It's the most reliable. It gives us the most latitude in order to customize it for patients. And you can see that we can resize the nipples as much as we want to. We can put them where we want to. We can follow these folds, like the lateral folds are easy to follow along the side to give contouring. And there's just sort of no other operation that allows you that much ability to sculpt the chest and to customize the procedure for whoever is coming through. And I think in terms of aesthetic outcomes, this is a particular topic that I embraced early on. You know, one of the criticisms of top surgery in some circles is that it leaves the chest more flat than you would expect to see in someone who wasn't operated. And one of the things that I sometimes like to describe this is in terms of proportionality. And so this is actually from an academic article that was published. And at least for my eye, this is certainly an acceptable result, but I wouldn't call it a proportional result. You can see that the chest is relatively flat compared to the rest of the body habitus. And if this had been left a little bit more full, it may have been more in context with the rest of the body structure. And here's an example of where we do try to achieve proportionality. And so you can see we leave a little bit of tissue behind, and hopefully that gives more of an appearance that you would expect if the chest hadn't been operated on. The other thing that we can talk about is the more commonly joined incisions in large BMI patients. You can see the gap here is very narrow, if at all, which means that there's likely to be some laxity or redundancy in the skin here. And so you carry the incision up to the midline in order to tighten up that area and give it more of a clean look. And then again, the axillary incisions, like we talked about on the prior slide, where you can follow these folds, like right there, all the way out to the side. And we can go back as far as the operating room table will let us go. Every once in a while, there might be a little bit of residual fullness in the back that would require a secondary procedure, but most of the time we can get that fold at the time of the first procedure. Okay, so finally, in terms of additional body contouring and liposuction, I think there is a tremendous amount of misunderstanding about the role of liposuction in body contouring. And suffice it to say, it is not a weight loss technique. And if we start at the beginning of where it's at its best, what's the ideal situation for liposuction? It's where you have somebody who just has a stubborn area of fat, like these little saddlebags. And frankly, no matter how much she lost weight, it just would not go away. And so you can see it starts here and it ends here. And with liposuction, it's a relatively small amount that you remove. So it's safe, it's tolerable. And this is where liposuction, like I said, is at its best. And then we go to the opposite extreme, which is where the amount of fat that has to be removed is very high. And the amount of definition that we're trying to achieve with liposuction is relatively low. And in that situation, what you get is higher risks, much higher risks when you remove a lot of fat, like when you start heading towards 10 liters, significantly more intensive recovery, because even though you're removing that fat, in some ways, you're creating what some people describe as like an internal burn, because everywhere where you're liposuctioning, you're causing this tissue trauma. And so when you're removing a lot of fat, it's a lot of tissue trauma. And I think, as I was kind of alluding before, you get less aesthetic benefit when you at that other extreme of liposuction. And here you can see somebody with a high BMI, and they had, I'm certain, several liters of fat removed. And I just am hard pressed to see that that did the patient very much good. And you can see in these MRIs that they were able to thin the fat under the skin. So that's what I'm showing here. And here it is after liposuction. But nevertheless, it's still just such a small proportion of the overall girth that it doesn't do very much in terms of what I believe that patient was probably looking for. And so again, the ideal situation is a relatively well-defined area of extra convexity that we can remove safely and have a reasonable postoperative course, compared to the high liposuction and much less well-defined areas of attempted body contouring. And so that's sort of my high altitude look at the role of BMI in especially top surgery. I wanted to make sure we had plenty of time for questions and answers, and I can go back to any of these slides if somebody would like, but I'm certainly willing to try to fill in any blanks that I've left behind.
Sweet. Thank you, Dr. Jacobs. We do have 3 questions in the Q&A box. Would you mind if I ask these questions to you?
Sure.
Sweet. This person asked, does being underweight or having low BMI also affect top surgery for tissue removal specifically?
So that's an outstanding question. As I listen to you ask that, I'm kind of thinking to myself, why didn't I include low BMI in this conversation? And the answer is absolutely, though it's pretty much all favorable, right? The lower the BMI, usually the more defined the anatomy and the less you have to extend the scars. And I don't, as long as somebody is well nourished, it's hard to think of any downside of low BMI as it impacts gender affirmation surgery or top surgery.
For sure. Does someone having DS switch bariatric surgery? Sorry, let me orient with this. Does having DS switch bariatric surgery to help lose weight cause any complications later with getting top surgery or eventually bottom surgery?
So the answer would mostly depend on two things. One would just be nutritional status. And so making sure that the nutritional status was in a good place before any elective surgery, obviously. And then the other would be the amount of skin redundancy from the weight loss. And so at some point, the gender affirmation surgery starts to overlap with body contouring in general. And that's how that plays out. And so we know there's a lot of body contouring after weight loss surgery. And in some ways, it would be analogous to that with the top surgery sort of overlaying the rest of the procedure.
Got it. Thank you. Someone also asked if you could go back to the BMI implication slide.
In terms of the surgical technique,
Sure, let's go back to that. And let's, Cassian, if you have a specific slide that you're looking for, we can put that on. This person asks, what is considered like a relatively small chest?
right. So again, one of the ways that we try to define that, and we're always trying to put definitions around these words to some degree, but that takes us back to this angle that wherever the angle between the sort of the bottom of the breast and the chest is greater than 90 degrees, that's probably fair to call a relatively small breast.
Got it. And this person said it was the five implications slide.
I'm sorry?
This person said for the slides, it was the five implications slide for
Oh,
BMI.
the introductory slide. Sure.
Yeah. Yeah. Great. Thank you. This person asks, do you have any advice for advocating for patients who are denied surgery based on BMI, especially a problem if they're low income and have limited options for insurance coverage?
I wish I did. I mean, I will share with you that my own feeling is that most surgeons don't say no just for the heck of it. Part of surgery is worrying about your patients. And I'm not trying to pretend that the reason that people say no is arbitrary. It's how they were trained. And to do something in surgery that you're not used to and wondering if it could hurt somebody is just about the scariest thing you can do in surgery. And so I think a large part of this is the challenge is finding surgeons who have been in that world of high BMI surgery. So they are comfortable and they do feel that it's safe for their patients. And even though it still bothers me because I think it's wrong to deny surgery for BMI, I do get the fact that most surgeons who do that do it because they're actually worried about their patients, even if they might be wrong, even if they might be wrong.
Yeah, for sure. And it also sounds like, at least from what I've heard numerous times from folks over at the Gender Confirmation Center, is that y'all do have that comfortability or that familiarity to be able to have a more nuanced and like complex conversation about like BMI and implications and figuring out how to get a yes through that process.
That's exactly right, right. It is because we do it, we're comfortable with it. We know it. It's not something that we feel like we're potentially experimenting on somebody or bringing in a risk that we're not totally comfortable. Sounds too simplistic, but that it's bringing in a risk that we haven't defined, that we don't know the borders of. And so we know what happens in the operating room. We know what happens in the post-operative course. We've seen it all. And that's really what, if you think about it, that's what surgical training is it's getting you comfortable with seeing all aspects and everything that can go wrong. So you know what sort of journey you're going on with your patient. And so I think probably the one piece of advice I might offer is if the surgeon doesn't do a lot of high BMI surgery, that might not be a good idea.
Got it. Thank you. And also curious, do you know of any other surgery centers who are pretty comfortable with doing surgeries with folks with high BMIs because it really honestly seems like, I mean, GCC is definitely one of them. And also there's so many people in chat in every event that we're in talking about being denied surgery because of BMI. And so curious if you would know of any other surgery centers that would do that.
Yes, a good question. I don't know for sure what other centers are doing. I do feel like this is making progress as even though it's kind of slow and painful, but that more people are getting accustomed to doing high BMI surgery. But I wish I could give you a better answer on other centers.
Totally. Thank you. Going back to audience questions, this person says some of their difficulty is sensory related as well as aesthetic. They don't want to have enough breast tissue left to still feel bouncy during activity. How would you balance proportionality and not just end up with a smaller chest that still acts with bounce on there?
And did I hear you say something also about sensation or just in terms of size?
It sounds like sensory wise, they don't like the feeling of like bounce with their
Oh, I
chest.
see.
Yeah. And
Right.
so the main question is around like proportionality while achieving that as a goal.
Yeah, absolutely. So I do think that as I mentioned earlier, the nice thing about the double incision surgery is it's so customizable. You can get to this level of proportionality, or you can be much flatter depending on what your goals are. And the other part that affects balance is how snug the chest is. And so even if you have some convexity, as long as the skin closure is relatively snug, it has much less bounce. But I often say to people when I'm talking to them for the first time, this is an a la carte world in terms of gender affirmation surgery. It really doesn't even matter anymore what your label is, whether it's a male look or a non-binary look or something in between. It is how large do I want to be? How tight do I want to be? How much do I want sensation? How much do I want nipple areolar diameter? It's really a la carte. And the beauty of the double incision is it makes that a la carte capability so customizable.
Thank you. And someone in the chat also asked about they're looking for top surgery without nipples.
Without nipples,
That would be the double incision, right?
it pretty much would be the I'm just thinking real quick before I answer that question. I don't can't think offhand of any other technique other than certain customizations like a fish mouth or something like that, which might be considered different than a classic double incision, and that could certainly be done without nipples. But by far and above, the most common approach to surgery without nipples is a double incision.
Awesome. Thank you. This person says, when I have top surgery, they will have lost 150 pounds. They have a lot of hanging skin. Is there going to be a limit to how much that can be removed at the time of top surgery? And will they be able to remove it from their arms and stomach at the same time as top surgery?
Right. And that too is very surgeon specific. I think the surgeons who do a lot of weight loss body contouring do much larger procedures in terms of skin removal than other surgeons. I think in our practice, we try, especially since we have a lot of patients who travel, we want to be really careful not to get into situations where we're more likely to have wound healing issues and people are far away and we can't take care of them. And so I would actually say I and the rest of us in our group are probably a little more conservative in that way. And so doing all of that at one setting might be a bit much unless you're local.
Cool. This person asks, what options are there for weight loss if you can't take a GLP-1 inhibitor and have genetic components to weight struggles?
I mean, I think the only other realistic alternative then is surgery.
For sure. Is triple E too big for double incision?
No, I mean that's the beauty is there's almost no size that's too big for a double incision.
Mhm. Amazing. What is the difference between the types that have drains versus no drains?
Yeah, that's another good question. So there are certainly practices that will do top surgery without drains. And I think that one of the questions that you have to ask in this is number one, how much trouble really is it to have the drains for 1 week? And what's the trade-off? And the reason why we put drains in, and I'm actually going to try to show you this with my hands, but essentially when we do top surgery, after we're done, we're asking the skin to seal down to the muscle. And even if there's a tiny bit of fluid in between, it can't seal down. The cells won't swim across that fluid. And so the purpose of the drains is to pull the tissue down so they're in contact, and that way they can heal and hopefully have better healing and fewer fluid collections. And so, yes, it's possible to do this without drains. The question is, how much of a trade-off is it to do this without drains? And so for all of the primary procedures that I do, whether it be keyhole or periareolar or top or double incision or buttonhole, I recommend drains. If I were having this procedure, I would have drains.
Awesome. Thank you. Which surgery would be best for a really small person with 34/36 Bs?
It's a little hard to say without seeing exactly what that looks like. I mean, it certainly sounds like somebody who might be a good candidate for a keyhole or a periareolar technique, but again, it also depends on what the goals are. And that, I often like to talk about this surgery as being 90% about goals and the rest being about the surgical procedure, because if you get everything right in terms of understanding what the expectations are and the goals of surgery, the day of surgery is a big day in somebody's life and a big day in somebody's journey, but hopefully not a big surgical adventure. This isn't open heart surgery. And so much of it is just getting the goals right and that we have the right marching orders from the individual undergoing surgery.
Totally. Thank you. Are there any concerns about taking GLP-1 inhibitors to lose weight for surgery and then stopping them after? They said they know research is limited just based on time these drugs have been around.
I mean, so there's sort of two aspects of that. One is we try to stop GLP-1 agonists at least a week before surgery because the stomach doesn't empty as well on GLP-1 agonists, and you don't want to have anesthesia with food potentially still in your stomach. And the other thing is, as I would say, I would not recommend losing weight for surgery with the plan of potentially putting it back on after surgery, because then you're sort of operating on a moving target. And it's best to be, if possible, at a stable weight and then operating. And so I think if somebody's thinking, I'll get in great shape for surgery with my GLP-1s, I'll have surgery and then I'll stop, my advice would probably be to either continue with the GLP-1 so that the surgical result is for the way you're going to be over hopefully the next many years, or to not take the GLP-1 in the first place in order to somehow optimize surgery.
For sure. Thank you. This person was asking, is there a certain weight that would be too much to have top surgery? There's a few, one asking about BMI over 50, and then one person asking about being at 325 pounds.
Yeah, so it was certainly pounds alone wouldn't do it because we really don't know what that means, right? And even BMI, you can argue is a little bit non-specific, but it really does boil down to what I was saying before, that in the operating room, it can become actually logistically difficult at certain BMIs. I think up to 50 is certainly within the range. I know every once in a while we've done actually significantly higher BMIs. There's no number, and there are certain situations where the anesthesiologist also will be sort of the gating step in terms of how high we can go. But I certainly think we can have a very recent conversation up until 50, and above 50, it's probably case by case.
Awesome. That's great to hear. And last one, at least in this Q&A box right now, is for those who travel, can they go on a plane with drains or does altitude matter on recovery?
That's a great question, and it comes up all the time. And so the issue really is not altitude. The issue is sitting. And whether it be in a car or in an airplane, what we worry about after any kind of general anesthesia is clotting. And as I said before, this really has nothing to do with altitude. And so I often advise people who have long airplane flights or long car drives for that matter to get up and walk around every hour, every hour and a half. And so if you're on a plane, maybe you can get an aisle seat. And then, of course, what else? The other thing you can do is put on your favorite music and try to drive the person next to you absolutely crazy by drumming with your feet the whole way. And that pumps the blood out of your legs and protects you from clotting. But it's important to really point out it's not the altitude. It's really the sitting. And you might say with the dry air in an airplane, you might get more dehydrated or something like that. But really, it's about the positioning and the fact that you're not pumping the blood out of your legs.
Oh, thank you. That is very, very insightful. I had no idea about that. And this person is asking about the GCC. Does your clinic accept out-of-state Medicaid for surgery?
I wonder if I can refer that to Z.
Yeah, I can answer that. Although we can technically take Medicaid, we currently have not had a high successful rate with the approvals. But at the GCC, we do offer complimentary consultations. All you would have to do is go on our website, go to contact us, fill out a form, and then you can get in touch with the patient coordinator for any insurance needs.
Amazing. Thank you, Z. And I put the website in the chat as well. Kind of last one coming in. If sitting is a concern, does that mean that wheelchair-bound individuals are not eligible?
No, I wouldn't say that at all. I would just say that we would want to do things that would try to mitigate the risk as much as possible, like not being in the sitting position without some leg raising every so often and trying to do everything we can to reduce the risk of clotting. And every once in a while, we'll even use like a DVT prophylaxis drug for somebody who has a risk factor that we can't otherwise mitigate. But I wouldn't say that it excludes the possibility, no.
That is great to hear. Thank you so much, Dr. Jacobs. That is
Very
currently
welcome. Thank
the
you.
last question. But yes, thank you so much again for just like your expertise and like your knowledge and just the resources that are being sent. Thank you so much, Z, for helping answer some questions in the chat and also providing resources as well. I'm going to copy and paste some ones that Z had posted just in case people wanted it top of the chat. Gender Band's Point of Pride, and for emotional and financial support with Trans Lifeline. And yeah, the Gender Confirmation Center is based in San Francisco. They have an amazing, amazing board of different board certified plastic surgeons. We've had many events with, I think, all of them, possibly. And yeah, Dr. Jacob Z, if you want to shout out like Gender Confirmation Center, if there's anything that you want to share about them, I would give you all the floor about that.
Z, I'll turn that one over to you as well, all right?
Yeah, here at the GCC, we're so happy to announce that we do offer complimentary consultations, whether they be virtual or in person. We have four amazing surgeons, and we're planning to grow very soon. Heard it here first, and we're just excited to see all you folks come on down. Send us a message, even if you have a general question and you don't feel like you're that ready to get a consultation, give us a call. We're here, we're open ears, we're open heart. Just come and talk to one of my patient coordinators, and we're here to help you, okay?
Thank you, Z. I think the fact that y'all do free complimentary consultations is amazing because I saw somebody in the chat say that they're in Arizona and consultations with a surgeon there was like $300.
Keeping it accessible.
Yes, I love. Okay, thank you so much, everybody. I will be sharing my screen just for some quick reminders and closing out. This webinar was recorded And so we will be providing the recording, some of the resources that we were sending in the chat, as well as a post-event survey. And speaking of post-event surveys, your feedback is always really, really, really important to me. It helps shape our future events. A lot of these events wouldn't have happened if it wasn't for the feedback that y'all had sent. And so if you're able to spend just like a minute or two, just giving us some info on like what went well and what could have gone better, it's completely anonymous. Speaking of future upcoming events, we have transfacial surgery part 2 with Dr. Fakeway. And then in March, we have a whole array of different bottom surgery related events with Dr. Lee. So really excited to be bringing her on again. And with that, that is the end of this presentation. We also have so many new events coming up in March. I'm really, really excited about it. I don't have them on this list at the moment, but I will be uploading them onto the website soon. Yeah, if you're looking to get a consultation, it is complimentary. Please take advantage of that. And if you have any questions, they will be able to help there too. Yeah, is there anything else, Dr. Jacobs, that you want to say?
No, just thank you very much. I know these are trying times, and we're here, and we intend on staying here and being a service, and we will do that for as long as we possibly can. And I will even express a slight optimistic note that I think that is going to be open-ended. And so I hope we get through this period, and anything that we can do to help is what we're here for.
Awesome. Thank you so much, everybody. Appreciate you all, and have a good night. Bye.